right. Good evening, everyone, and thank you for joining us for tonight's Woo You event. We have a really fun event planned. We're going to review a bunch of cases that were submitted to us from you all. And what makes it extra exciting is none of us have seen any of these cases, so it'll be fun. Maybe there'll be like a little bit of spice that that our doctors will add to it. So this is our dream team here. I have Dr. John Gillies, Dr. Nathan Schramm, and Dr. Brooke Messer in the house. I'll be your host tonight. My name is Dr. Ariel Sorenzi. So start with John here. He is the director of the Specialty Contact Lens Division at the Cornea and Laser Institute and Center for Keratoconus.
You don't have to read all that. That's okay.
Well, I want just everyone to see all of your what do you call it? FAAO, all of your acronyms.
Oh yeah, all those letters up there.
That's yeah. All right.
How many letters do you have?
A lot. How many do you have, John?
37.
More than are in my name.
Well, he's obviously a scleral lens guru, and we're excited to have him.
Thank you. Happy to be here.
Then we have Dr. Messer. She received a doctor of optometry from SCCO, and she is very passionate about specialty lenses, myopia control, and advancements in anterior seg surgery. We'll get to hear about some really cool surgeries that her and her team did in one of the cases. We did have a sneak peek at the beginning at one potential thing. So he is a fellow of the American Academy of Optometry and I just lost my screen. There we go. And Scleral Lens Education Society, serves on the education committee for the North Dakota Optometric Association and is the optometric residency program advisor for the Vance Thompson Vision in West Fargo. All right, and then last but not least, we have Dr. Nate Schramm, who serves as the Chief Medical Officer and Director of Specialty Lenses at Insight Vision in California and Nevada. Just recently bought a new practice. He is the founder of the Scleral Lens Practitioners Community and co-founder of the ICSC, focused on specialty lenses for regular corneas with a special interest in scleral lenses and wavefront guided optics. He's the fellow of the Scleral Lens Education Society and the British Contact Lens Association, and is committed to education, research, and helping clinicians feel confident fitting sclerals in everyday practice.
I'm also working on trying to get some more initials after my name too. Hopefully, good.
I'm not.
All right. Well, let's go into case number 1. So we have a 52-year-old female with long-standing keratoconus, corneal cross-linking approximately 5 years ago, current scleral lens user, and the most recent fit was AccuLens Maxim 3D. So in the right eye, we have optimum extra material. We have our power there and our diameter. Left eye was a wave and optimum extra material. Here are our base curves and overall diameter. So 6 months after finalizing the fit and vision were still looking good. 1 year after finalization, the patient notices a bubble in the left eye when looking at the mirror in the cornea and has hazy vision. Examination shows hazy edema. OCT shows high drops. So they had the patient discontinue the scleral lens immediately and started Pred Forte 1% QID. 1 week later, the cornea specialist added COSOPT BID to reduce corneal stress, Miro, and reduce Pred to BID, and also suggested that if the high drops did not resolve, an air bubble tamponade to reattach the Descemes might be helpful. Approximately 4 days later, patient calls with severe chest pain and believes it is the eye drops. He was switched to Alphagan 3 times a day, advised if chest pain continues to go to ER to rule out other cause. 5 days later, the patient went to the ER and was cleared for a regular cardiologist visit with stress tests thereafter. 1 week later, cornea is much clearer with new bubble curvature remaining. OCT shows Descemes is mostly back to normal with a small defect remaining. They have not resumed the fit yet. So here are some of the pictures of the eye drops with tomography here and OCT on the right. And then we have a video just going through the cross section there.
You can see the Decimate detachment.
Mm-hmm. I'm surprised, at as many KC patients that rub their eyes and still rub their eyes, that we don't see eye drops more often. Like I see keratoconus patients, you guys see keratoconus patients every day, and like eye drops are just not that common.
Mhm.
But anyway,
I
yeah.
agree with that. I see like 500 a year, and I see maybe 500 patients with keratoconus a year, and only see like maybe one eye drops per year.
Yeah, it's like so rare that we see eye drops, and it's just they continue to rub their eyes, and of course we tell them not to, but it's just part of the way their eyes heal and all that. So I just I'm surprised we don't see more of it.
Has there ever been any studies done on? It seems like the patients that come in with eye drops, in the last 3 or 4 or 5, they all hadn't been seen in a few years. But I saw that this patient was it had just been a year that they had been seen. But I wonder if there's anything to do with compliance.
Mm-hmm.
Yeah.
They just need more reminders too. And I think, routine eye care, they're more likely to have, like pat a day or, something like that on board as well to try and decrease eye rubbing. And, I always tell patients, like, we just do whatever we can to try and, turn down that, that desire on the just screaming of the eyelids especially when the lenses come out, that's when they want to rub their eyes the most.
Yeah, get the
How many have you asked your patients why do you rub your eyes? Because the common response that I get, and I'm not sure if this is what you hear, but it's because it feels good.
So good.
Yeah. And I'm like, you got to stop it, even though it feels good. Don't do that.
Yeah.
All right. So then here are some of the pictures. I'm assuming this the April one, I guess, after Scleral Lens was put back on the eye after it was healed.
Oh, let's see. So the April one.
No, that's 425. So that's pre-cross.
Yeah, so that's pre-eye drops, right?
Okay.
And you can see that there's no Decimase detachment on the pre-eye drops.
Mm-mm.
Yeah. You point to the inner. I don't think I can point on the screen, but yeah.
Okay. Cool. Let's see if there is a slide after this.
Oh yeah, you can see the Decimase detachment actually on the top right.
Yeah.
Okay. All right, cool. Any slides that you guys want to go back to?
Yeah, I think that's pretty good. I think eye drops is kind of an interesting thing. I think really when you look at it, there's there's a lot of things out there. I mean, I would consider our team pretty apt when it comes to management of keratoconus, and we're kind of if the patient is inflamed and uncomfortable, throw a little pred on it, but we're not big into tamponades or mini grafts or compression sutures or any of the other stuff. It's kind of I'll just let it resolve and go from there. You'll have some some hero cases where they throw some gas in there and you get fast resolution. Yeah, exactly. You get the fast resolution on some of them, but then you get the cataract on the other one. And, I mean, having that in a 25-year-old is enough to make you not want to do it again. So, I'd say for us, I don't know, Brooke, Nate, Ariel, when we look at these patients, are you guys doing anything different? I mean, we're kind of a wait and see.
Yeah, I would consider a prophylactic antibiotic if the ocular surface shows a lot of bullae, and then like some pred, Miro. Even though I don't know that Miro helps a ton, but and I think it's okay to put on aqueous suppressants to decrease just the stress on the posterior cornea. Most patients are going to have that timolol, reaction, but patients tend to do okay. Especially if the cone is inferior to the visual axis, the scar is going to land there, and then they end up sometimes a little flatter than they were before, and they do okay. So I don't get too excited about eye drops, other than just reassurance. See them every couple of weeks as they resolve, and again, keep reassuring. And they'll probably need a new scleral fit because their cornea will be way different post eye drops, and so they'll be refitting at the end of it.
There's a recent case report where the eye drops resolved in 21 days. How did they do that? And it's only a single case. They put on Rochdal, which is a ROCK inhibitor, the Rho kinase inhibitor. And I haven't seen it duplicated again, but it's something maybe to consider. But if they have a corneal transplant and they have eye drops, you definitely don't want to put any ROCK inhibitors on there because you end up with like keratopathy. But yeah, this was published at University of British Columbia. Greg Maloney and Dr. Salami. Had any of you ever tried any inhibitors? Because I've heard pretty mixed results on that.
No, I would say, you have some people that'll use them for like DSOs or, other sorts of endothelial, like DWEC or, DSO to try and get your, endothelial proliferation. I would say when you look at it, I don't know, I'm kind of jury's out on it. I feel like, personally for me, I think the best thing on this is, again, time, or if you have somebody who really, really needs it or is dependent on it, you could make the risk benefit choice of, throwing an air bubble in there. But yeah, I mean, there was some interesting case studies because I think it was Benny Jang's group out of Maryland that did the like mini DMEX. Where they would do it was like a 3 or 5 millimeter DMEC that they would put in, and basically just patch the Decimays in that area. But now for you guys, like, I don't know, for us when we're doing, let's say the patients in scleral lenses, at what point are you saying, hey, go back into the scleral lens, or hey, it's fine to wear? Where are you guys on that spectrum? Are you kind of let the majority of it detergest and then go back into it when it's good enough that the lens actually fits again? Or are you kind of a not until it's all the way clear?
Oh, you're on mute.
Mute.
I accidentally made my picture gigantic on my screen and I couldn't see anything. Anyway, John, I would, if the cornea is a little edematous, I wouldn't be, but the epithelium is closed. I wouldn't be afraid of like a scleral lens trial, have them put it in the morning and show up at noon and see what's going on, see how the cornea is looking, especially if it's maybe their better seeing eye or something like that, where it's harder to, like the patient is just aching to get back into their lens so they can get back to work or whatever. But that's what I would do is tell them to put it in at 8, come to the office at 9 so I can see how you're doing.
Yeah, I agree with that. I think the thing with it for us, we do almost identical, like put it on, see how it's doing, like have them come back. If the cornea is more swollen than it was before, I mean, it was a little early. But in general, if they're doing pretty well, the epi's not sloughing, you're not having, big bulle or anything like that. I'm fine with letting it ride with the eye drops there. Nate, what about you?
Yeah, I agree. Ariel, can you go back to the case history real quick? But we don't have a cornea specialist in our office, unlike the two of y'all. So typically we send over to UCI and then they send the patient back to us when they think they're ready to be back into a scleral lens. But yeah, I would take the same approach if I was treating it, do a 4-hour tolerance test and make sure there's no bulle, and that they're not getting any more, edema, microcystic edema. And also, we'll usually take the lens out and do a pentacam topography, check the pigmentry. Yep. And also, best corrected vision is important too. Is it getting more foggy there? This patient said that they had after 5 days, 4 days severe chest pain. So they're using Cosapt, and severe chest pain goes to the ER. I have some thoughts about that, but I'd love to hear what you all think about why that occurred. John, I see you smiling.
Yeah. Yep. Good old Cosapt, man. I mean, I don't know. I've always looked at these glaucoma medications as, are we going to or are we not going to? And, what's the potential side effect for it? And very well tolerated, but every now and then you may have that one patient that, so I don't know. It's a tough one on that. I mean, for me, I don't know. I can tell you in our clinic when we've done it, I've never seen a difference in resolution time between giving somebody, a pressure medication or not, So I'm, on the aqueous control side of things, I don't know. I don't think it really does a whole lot. And the downside is, you'd need a lot of patients with high drops to get a good study on that. So I don't know, it would have to be like a night and day thing for me to be able to go, yeah, that's what we're going to do, but again, that sort of severe chest pain sort of thing. I mean,
I was thinking that he might have had a panic attack. Actually.
I was wondering about anxiety too. Actually,
that,
just it's not getting better. It's been this long. I'm on eye drops.
It's also true. I mean, this is actually the funniest part about this case was literally last weekend. My on call on Sunday morning was a KC patient when my vision got suddenly blurry, my eyes kind of watery and irritated, and immediately you're going, okay, clearly it's eye drops, So yeah, it's definitely definitely a component of it, the level of anxiety that comes along with just sudden onset of blurry vision and some irritation. So
I had a very similar case, but the patient had put a second scleral lens on top of his eye, and there was a bubble there as well, so he thought that he had eye drops. And when he had come in, the technician tells me oh, you can't see, and it looks real. His eye looks like there's something up with it. Turns out he's got 2 scleral lenses on.
So, question that I have, just being on the consulting side of this panel, is: do you guys recommend that they return to that habitual lens, or are you guys refitting once things have kind of calmed down with the high drops?
Every case is different.
Yeah.
So I would put on their habitual and then see what it looks like.
Yeah.
Some have a bunch of flattening, and so then they might even need a different profile of their lens. Others just can go right back into it, maybe a little power change.
Right.
There really is no specific rule to that approach, but put the lens on, see what happens.
Yeah. Perfect. Yes. And I was going to say, and on our consulting side, we honestly, like you guys said, we do not hear a lot of high drops. I can maybe count on one hand how many times I've heard, patients high drops, took them out of their lenses. Now we're refitting, so we don't hear it that often either.
Yep.
And Nicole, I'm really sorry I did not introduce you. Could you give us a little background on yourself and just tell us a little bit about yourself?
Yeah. So my Nicole Edwards, and I actually work for Bausch & Lomb. I am the manager of the specialty vision team for both the US and the UK team. And I'm happy to be here. Danielle was supposed to be here, Danielle Nesbitt, but she is traveling abroad for some work to do with for Bausch & Lomb, and she asked me to step in. So thanks for having me, and I appreciate it.
We love having you.
Thanks.
And for the audience,
this lens was not a Bausch & Lomb lens in this.
I know, I saw that. I was like,
And guys, feel free to ask questions in the Q&A, and we'll make sure to answer those for this case.
Yeah.
So we have about 10 minutes left for this particular case. Let me ask you guys from a practice management side of things. Like Nate, I know that you accept insurance at your practice, and Brooke, I believe you do too, right? Yeah. And John, you don't, so this will be too. What kind of conversations are you having with patients on kind of like the financial side of things? Like, can they accept think that their insurance is going to help them pay for a refit, or what kind of conversation are you having?
Well, since most of the time these are patients that have been wearing the lens for longer than a year, their insurance has usually kicked back in that we're going to be able to refit them with a medically necessary. Actually, they don't call it medically necessary anymore. It's called visually necessary, because a lot of these insurance plans or vision plans no longer care whether the patient has severe dry eye. If they can see 20/20, then they're not going to be covering the lens. So, but fortunately with keratoconus, it's a different story. You're going to most likely be able to improve them 2 lines of vision. And like I mentioned, we would usually refer to a cornea specialist for the management of high drops when it happens, because then they could potentially offer some sort of surgical procedure as well.
Yeah, we take medical only, so don't have the vision benefits. And of course, every visit related to the high drops would be an office visit, so 99 code. When it comes, if I needed a new scleral lens and they happen to be, mid-year and otherwise wasn't ready for a new one, it's a tough call, because these lenses to everyone, they're expensive to patients. And, I would probably do what I could to, maybe give them like a small discount or something, but that you don't have to. But unfortunately, if we're starting a new fit, then we're starting a new fit.
Mm-hmm.
Yeah, I'd say on this, it really depends on where they're at with the habitual, right? If you get one of those high drops where, you're similar to flatter than where you were, and the visual acuity hasn't really changed, and the corneal profile, maybe you gained 100 microns of sag because the cornea is now, lost 100 microns, right? So you've effectively gained your 100 microns. I would say it's one of those that in many cases, especially if it's their non-dominant eye, right?
Let it ride.
You let it ride, you know? I mean, if you're okay, like maybe you get a line better with an over refraction. Yeah, that could wait,
Yeah.
If, if it's the difference between, paying rent or, or having a line of vision in your non-dominant eye, like let that ride.
Yeah.
On the other hand, if this is, your dominant eye and, your 20/80, but an over refraction get you down to 20/25, like that's an entirely different conversation.
Mm-hmm.
Yeah, we're doing the new lens and going from there. So yeah, definitely
and sometimes we get clever with it. Like we keep eyeglasses in stock that we ordered from some online site, and so like +1, +2, +3, and also in myopic eyeglasses, and we'll just give it to the patient as a loaner. So if they need to, if the prescription shifted, like say 2 diopters, we could just tell them, hey, you can borrow these glasses, pop out the other lens, and they'll be wearing a -2. It might look a little silly, but we do try to help the patient out temporarily until they can afford to get the new lens.
Yeah, I mean, I remember doing those for the Ortho K patients where you're like step down treatment or step up. Yeah.
At one point, this was back in the day, there was this thing called the ad lens where you twist.
Yeah, the like
really
little
ugly, but you could put between like a +3 and a -6 in there. But
yeah,
it was
That's
really
pretty
ugly
cool.
looking design there.
We had a question come in. Would a topical carbonic anhydrase inhibitor be contraindicated in this case?
So there's some thought that CAIs can impact the endothelial function, and maybe that's what they're implying here. And so I don't know that I would reach for it. And again, like you said, John, we just don't have a ton of data on how impactful aqueous suppressants are on hydrops recovery. And so I don't know that it would be contraindicated, but when we have, like in our practice, if we have a patient who has glaucoma and they have a touchy graft, I'm probably not reaching for a CAI if that graft is old, kind of borderline failure sort of thing, because of the potential impact for the endothelium. Please reach back out if that's not what you're implying, but there are some thoughts that CAIs can impact endothelial function. So I don't know. I probably wouldn't. I mean, I probably would have done something like Combigan on this case rather than COSOPT. But not necessarily wrong. I don't. So, but I would have done Combigan if I was reaching for an aqueous suppressant.
COSOP put him in the hospital.
Yeah, but it was maybe the Combigan would have put him in the hospital too with the timolol in there. So
would have had a panic attack either way.
Yeah. So
can we show? Oh, go ahead.
Oh, I was just going to ask, is there a minimal thickness that you guys look at? I think you all have tomography. Is there a minimal corneal thickness that you would be okay, or that you would decide not to fit a patient in Scleral Lens? Brooke, I'll have you go first.
I would say that again, a minimum because of
just worried about inducing like some sort of like hydrops episode or like a perforation, for example.
Yeah. I'm probably not worried about a perforation. And as far as like, creating like a desmetacel or something like that, again, like they're just so infrequent that if I was concerned, I would. And unfortunately, like these eyes that are super thin, they're also going to be extremely coned. And so we're not, a corneal GP is not going to fit on these patients either. And if I was concerned, I would maybe fit them on the edge of just having like nice and loose, minimal suction, something like that. But again, if we're down to like, 270, 250 pack, I don't know, their vision may be so distorted that perhaps a PK is a better choice depending on the rest of the patient case. But I guess I would probably try a scleral first. I'm trying to avoid a PK at all costs in most cases. I'd let it ride. I'd give it a try.
I have a fragile cornea patient, which is like extremely rare, and her corneal thickness is probably less than 100, maybe 75. Like you can't really even measure it. I was measuring with the anteriors like OCT, and it was getting like 75. Jeez. And like Brooke said, we just went loose with the fit. And when she was pregnant, she was actually considering like, should I have a cesarean because just the pressure could it rupture the cornea? But we did a lot of research on that and even asked a few OBGYNs, and they're like, no, that's not going to rupture. Like, are you sure? I mean, it's 75 microns, but I think she ended up having a cesarean section just because some other issues had occurred. But that's my thinnest cornea, I think.
Wow.
I don't remember what my thinnest cornea would be. I mean, maybe 180. I'm not really sure. Definitely not as thin as that.
I don't know. I mean, we've done desmetacels, so it's. I mean, we're pretty. we're pretty in there for the thin stuff. I mean, I would say, I mean, Gloria had that paper on
Gloria Chu.
Yeah, Gloria Chu had this paper on managing a desmetacel with a PROS lens. And she didn't just have the one paper; she had like a 5-year follow-up on it. And this guy has probably 5 millimeter desmetacel. It is wild, and it's been stable. I mean, it just really tells you the strength of the desmase membrane. I mean, that is. I mean, it's the reason they started doing those DMAC or BMAC procedures where they take the desmase and then doing a superficial keratectomy and then lay that down on the Bowmans because it's so tough. So it's it's pretty cool. But yeah, I mean, we've I think we published that case study. It was a patient that had like an neurotrophic keratitis and exposure, and had like a central, like probably 3 millimeter desmetocele that actually over the course of like, I think it was like a month and a half actually, closed. So it, I wouldn't be super gung ho if you don't have a cornea specialist in your practice that, obviously has some cyanoacrylate glue to take care of things if it does rupture. But, at the same time, I wouldn't say it couldn't be done.
Cool. Well, that's it for case 1. Let's hop on over to case 2. All right, so case 2 is a 25-year-old female, first-time scleral lens wearer for keratoconus. Prescribed latitude lenses. SMAP captured a false elevation in the left eye, which caused the lens to have a lot of edge lift and a constant bubble upon dispense. So the SMAP was retaken, an OS lens was reordered and sent to the patient's house. At the first follow-up, there was latitude for the right eye, Europa for the left. Left eye had significant edge lift still and was constantly rotated 50 degrees to the right. On manual rotation, lens will go back to their original rotated position, 50 degrees to the right after 1 to 2 minutes. The left eye spherocell over-refraction was very variable and unreliable based on where the lens was rotated on the eye. Next steps was to decrease the central clearance 150 microns and steepen the edges to try to stabilize the rotation before adding that spherocell over-refraction. So for that right eye, this is the base curve power with that spherocell, 16.5 diameter, acuity 100 material. Looking at the fit, it was centered, 0.5. Do you guys know what MOB stands for?
Oh, moving
on blink.
Oh, moving on blink. I haven't used that acronym before. Central clearance 427 microns. Excessive limbal vaulting 360, superior edge lift with bubbles entering the lens, scleral lensment alignment everywhere else. Black dot was now at 6 and stable. Left eye fit was centered, 0.75 movement on blink, central clearance 385, excessive limbal vaults, lens rotated 50 degrees right, unstable edge lift superiorly with entering bubbles with manual rotation to proper orientation. Still seeing that lens re-rotate. Let's see here. Significant lens deposits. Then we can see that variable spherocell over-refraction. And the plan was to adjust the left lens to correct fit and stabilize lens before incorporating the power change. And the patient is scheduled to follow up in a few weeks. Let's look at some pictures. So here are some OCTs of those edges for the right eye. So we have central clearance for the right eye in the top left, nasal edge, top right, temporal edge, bottom. Oh wait, no, I guess I said that backwards because it was the right eye, temporal at the top and then nasal at the bottom.
Okay.
I can't really, I'm trying to zoom in to see what that caliber was measuring for the limbal clearance.
427 microns.
For the limbal?
Oh, for limbal, I'm sorry. For the temporal side, it's 381, and nasal is 182.
Wow, great vision.
Who's your eye doctor?
He's the only one that wasn't leaning into the screen.
Oh, what are we doing?
Oh, you probably have it on full screen, huh?
You are correct.
Yeah.
I just want to see all your faces. Okay, let's do the next screen here. We got a video. And it's showing that movement on blink, that MOB. So what are you guys looking at here when you're looking at this picture or this video?
Maybe I'm less familiar with the design, but why are we trying to get the dot at 6? Like, does it matter where it goes as long as it's stable?
Yeah.
I think they ordered the first lens with astigmatism correction in there, so I don't know if they were assuming it was going to be at 6 o'clock, 0 degrees of rotation. So
Yeah, I mean,
That's
it's
why the
you
left
just do
is
like a soft
really
lens, right? Like Lars and add
Lars,
the
yeah.
OR and run with it. I guess I would just leave it. I don't really care about the rotation. You know, it's like if it was a profilometry driven fit and it happened to be like made a little opposite, or maybe the head was tilted or whatever it was on the scan, then just correct the power. Again, like I don't care where the dot goes as long as it goes in the same place every time.
exactly. Yeah,
Yeah.
and this one is a profilometry driven. The
Exactly.
latitude lens is based off the SMAP, which is a profilometer.
Okay.
Wait, the latitude was on the right or on the left?
I thought
The latitude is on the right.
Yeah, latitude's on the right.
Got it. So that was the latitude that we just.
That was the latitude. Yeah, that's
I mean, can you go back one, Ariel? I thought the fit looked pretty good. I mean, it was going up and down a little bit, but not a ton.
Terrible. Yeah.
I think, you know, I'm a little old school, but I like to see fluorescein on my first dispense because I just want to see like where's my good clearances, and especially when you're looking at like lens centration. Like to me, that makes me feel like looking at that one there, like that looks like there's maybe some conj prolapse
Mhm.
right above the dot.
Mhm.
So to me, that tells me the lens is inferior, decentered, and
Yeah, and you can see here as they're looking down, you see that little line of blanching that happens
Yeah.
up the superior
Yeah.
edge.
and it's like
Yeah.
hanging on by a thread up there. So it's
Exactly.
inferior,
But that's a,
decentered.
like, you know, faux blanching, because when you actually, if you held both lids out of the way, what would end up happening is that lens would drop.
Yep,
Right.
totally. Both lids out of the way and look at it that way. So yeah, I would I really love having this is just like a simple thing, but on most slit lamps you can purchase just like a little diffuser that goes onto your light, and then you're not looking through this like tiny beam, you know, so you flip your diffuser up, then you get like a big broad light.
Yeah.
And then you don't have to move your slit lamp around to like look at all these things. And maybe this just might be the slit lamp camera, but I like to mag out as much as I can when I'm looking at the fit. That's one error that I think residents and students make is they hyper mag and they look at all these like parts individually rather than like low mag and zooming out and looking at the whole thing.
Yeah. I think
But that's pretty good. It's not that bad. I don't see a lot of trouble with that one.
Yeah, like if I were looking at this and like being like super hypercritical, if you went back to the OCTs here, like, yeah, I'd say we're like overvaulted at the limbus. So if we drop down the limbal clearance like 100, and like let's say that we wanted to tighten up the edge, you know, 100, 360, we'd probably get a pretty decent, you know, overall fit on it. You know, you may want to tuck in the limbus a little bit, you know, on the vertical if you can. I can't remember.
Make the chamber smaller in that?
Yeah, exactly. If you made the chamber smaller in the vertical direction, you end up closer to the limbuses and ends up kind of almost locking the lens in place from kind of vibrating back and forth. So you get rid of that little bit of space. But honestly, like that wasn't so bad.
Yeah.
I was really nitpicky, and the patient, like let's say the patient was complaining, the patient was telling me, oh, I'm getting debris under the lens, and you know, things are kind of getting cloudy, or hey, you know, I put the lens in at the beginning of the day, but by the very end of the day, I have a little bubble there. Like, sure, I'd say, all right, let's steepen it, you know, 100, 150 microns all the way around and drop that limbal clearance a little bit. And, you know, I think that would be my move. I will also say pretty brave putting the astigmatism correction on lens one.
Yeah.
Like got a lot of trust in that fit being pretty stable.
It's like the brave slash of scleral fitting.
Right.
Can we go back to the anterior seg OCT?
Yeah.
Yeah, I was gonna
say, what do you guys think about though the overall sag though too? Did they say how long the lens is on eye? Because
you can.
that was one of the things I thought of too, with it just being so overvaulted centrally too.
Yeah, and that's definitely that's exactly what you're seeing there. Like you're getting that really high center, and then you get that fast dive.
Exactly, it's just kind of
Yeah, if you lowered that would bring down your limbal clearance just by that lowering.
Right.
You can
It'd
see
be
there's
interesting. Oh, sorry, Don. Keep going.
you can see there's some midday fog there
Mhm.
to the mid periphery on that central scan,
Yeah.
which
So one of the
clearance. Yeah. Oh, go ahead.
hot topics at ICSC, and all of you were a part of some of this discussion, was where the heck is the limbus on the OCT?
Oh, I love this.
So can you, let's see here, Nate, how about you describe kind of what you look at to roughly see where?
You can't see my pointer though, but it kind of, oh, I guess you can see my fingers though. It kind of creates a little bit of a V there. And I kind of look above that. If you can see the scleral spur, it's usually just above the scleral spur as well. Lynette Johns did some good papers on this of drawing out the limbus. How do you guys look at the limbus? And the other way is just look at the where the beam is. You can, with this type of OCT, you can see that there's a little line on the one on the top right image. There's a line that goes from top to bottom. That also correlates with yeah, exactly. That correlates with a little tiny line in the circle where there's the compass looking thing where all the rasters are.
Mm-hmm.
And so you can kind of determine where does the color part of the eye, in white and cornea, where do those all link up? So that's another way to determine, at least for me.
Yeah, I kind of look at like the change of tissue there, like you were talking to, like that V in the color change. And I think with the lens off, sometimes it's a little easier to sort of see like the conj epithelium and the cornea epithelium. But I think this lens lands nicely. We're not, as far as like chamber size, nasal temporal, we're not oversized in that area. But I do think that the base curve on this lens is maybe a little flat. I would shallow it up and perhaps like, it's tough because the cornea looks so flat in these OCTs in the nasal temporal scans. Like I kind of want to see more of maybe even the mid peripheral cornea. So I would take that like center scan on the top left and just move it over the mid peripheral cornea so I can kind of see what the cornea looks like there. But the top right image, it makes it looks like the base curve is so flat and that it just dives down.
Yeah.
And that's creating that overvault. And so, utilizing the central base curve and maybe just the way these images are portrayed, it kind of distorts the cornea a little bit. But I'd be looking at when I have a lot of lens movement, in addition to like the limbal clearance, not only where it lands, but the approach, also just like the shape of the lens compared to the shape of the cornea throughout the whole thing.
Yeah. I think when I'm looking at this, like I'm like exactly what you said on that last one, Brooke, is like that translation between where your corneal epithelium stops looking like corneal epithelium. Once that ends, that's the limbus, right? So, when you look at this on the horizontal, you're doing great, but we can know based off of just, corneal geometry, our vertical is not going to be as wide as this. So we're going to be even further beyond that. So you're giving that extra space there. So I think, those oval zones, or maybe, the ability to kind of, do basically a bitoric sort of, or a toric back chamber, can really get you that area where you're coming in a little closer on that vertical and get you a little bit less of that excessive clearance there. So yeah, I mean, I think big issues here. You're overvaulted, and you're overvaulted. So
the other thing is, I try and gather my OCTs if I am taking edge images in primary gaze. I think the lens can shift a little bit when you're looking left to right. So I would, have the patient look forward and move my OCT to the edge rather than looking side to side.
I was going to make mention of that because we get that quite a bit, is where it's such an extreme gaze when we're getting images sent to us for problem solving. It can really kind of obscure what we're really fully looking at. So thanks for mentioning that, Brooke. That was one of the things I wanted to bring up too.
Yeah, it's a good point, Brooke. But some of the OCTs just don't let you pivot at all. Yeah. And or scan.
And even then it's like, if you're not capturing the image, like the image doesn't have to look great. just move it over there and look what's going on. Use it just to see. And then if you can't capture a good image, that's fine. But hopefully you can at least see the relationship a little bit better.
Yeah. So this is going to be our left Europa lens.
Okay.
And it looks like, is that just
There's some edge lift down at the bottom there.
Yeah.
Yeah.
it looks like maybe they painted the lens with fluorescein, perhaps?
Yes.
Kind of a lens.
So you can see that it's coming in probably from the bottom. It looks like
Yeah.
they probably painted it with fluorescein and then immediately took the OCT.
I mean, you can look at this and just, I mean, right away, there's, you don't get that big gap between the tissue and the lens without having, sagittal depth mismatches. So,
If you zoom in, like that entire temporal edge is completely floating. It's not even touching the conch.
nodding contour. Yeah.
That's really neat. That's a really neat picture.
Yeah.
And
You get that when you're like
what you think
really mismatched, and like when you look to and it happens in extreme gaze, right? Like you're never gonna get that view if you're in, straight gaze. When you're in that extreme gaze, what ends up happening is as you're looking to the right, your lens is getting shoved to the left.
Mm-hmm.
And you can really see that gap open up.
Yeah, and then you have the overvault there again with that central scan too. So
yeah, and what looks like the nasal side there, I mean, you're hitting on the tippy toe. Right?
Yeah.
There's just not much landing zone work going on here. Like, again, like you said, like just the very edge of the lens is hanging on to the eye here. And so it's, again, like I'd like to see some mid-peripheral steepening of the lens so that I can pull the heel down of my landing curve to try and utilize a longer landing zone. This is the Europa. Yes. And so the Europa has like 2 or 3 landing curves, right? And you can customize all of them.
it has at the haptic, it has 2. So there's 5 total zones, and there's a toe and a heel that you can, that's number 4 and number 5 that you can.
Yeah. So 4, I think, is like 1.5 millimeters long, right? If you're going on the 18 diameter, a bigger lens. And then the outer is small. So that's more of, but so that longer curve 4 is kind of, I think, the workhorse curve for the landing. So I would really work hard on getting that one down so you can actually utilize it to seal up the lens.
Yeah.
Maybe need, again, like it might have just been a bad SMAP scan. And so I think if this was my first lens, I would just go right to my diagnostic set and put a different lens on. It's probably more like, didn't get a good scan, so it's harder to adjust a lens that's not fitting well. Like, go grab a diagnostic lens, put it on, and see where that takes you.
I think there was also like a big overrefraction. Wasn't there like a plus 350 overrefraction? Which I know when you work with B&L lenses, if you accidentally grabbed one away, like you put one base curve away, you end up with a 3 diopter miss.
Exactly. Yeah.
So that's left. Why is there a red dot on there?
I think it's a little concheme.
Yeah. I mean, the other thing too is with their slit lamp technique here, if you're using that light totally in click, right? Like you're not understanding the depth of anything that's happening there, right? Because you're just getting straight projected, collimated light. You got to kick that thing to the side and you would see all the mismatches in shape. I think that's again, like another, tip that we try to teach our interns, fellows, residents, all of them, is kind of, look, you're going to throw it to the side, take a look at it, throw it to the other side, and that'll really give you an idea of the alignment there. The other thing that I found that was always really, really good for looking at edge alignment in the superior quadrants is literally throw a optic section and just watch that optic section as you're going over the lens going into the lens going onto the scleral conjunctiva, and you can watch as that beam bends, right? So if that beam, because you can see obviously the conjunctiva going underneath it, if that beam is bending because of the edge, we know we're too tight. If that beam is looking aligned out here, but you can see the bend inward towards the limbus, you're too flat in that area. So, or too overvaulted around the limbus. So you can really, get a better idea of this. But if you really want to know what's going on with the lens, take it off and stain the eye. Right away, if you're ever confused on an eye like this, where you're going, well, that looks pretty well aligned, take the lens off and put some fluorescein on and just look at what the conjunctiva is doing. It will tell you the whole thing.
Right.
If it's too tight, but if it's loose, then putting fluorescein in on top will tell you where it's coming in from. Just like here, you can see that it's rushing right in where we had that anterior seg OCT was really, you can even see the edge lift there. This is like a GP edge lift.
Oh, wow.
It's really loose on the bottom, isn't it? Can we play it one more time?
Yeah, so you're a little loose there, and temporally, and then it's sitting low because it's falling, so it's just kind of using the edge of the lens there to just kind of brace itself. But yeah, that nasal edge is quite a lot.
Sometimes I'll manually push with my thumb across, move their lid across the fluorescein, because at times when you put the fluorescein in, you're like, is that on the front of the back or the back? So just by forcing their lid closed, you can tell if it's making it behind it or in front of it. It's one of my quick tricks.
So if we say that, like for the Zen lens, for example, one step is 30 microns of change. What would be a meaningful change to you guys in steps or microns? I'll have Brooke answer that first.
So if patients are complaining like, oh, I can kind of feel this edge, and or they say like, I'm mildly aware of the lens, if they're like, I ask them to squeeze and like tell me where it's feeling it, and if they're like, oh, it's right here, so then I'll look there. To me it looks good, but they're complaining of an awareness, then I may steepen the lens edge by say like 30 to 50 microns, something like that. Whereas if I'm seeing like edge lift, obvious edge lift, when I'm swooping that slit lamp back and forth, like you were mentioning, John, then I'm looking at more like 50 to 100 microns of change to make an obvious change. And if the edge lift is even more obvious than that, then I'm looking at more like, 100 plus microns of change.
Mm-hmm. Can we go back to the OCTs?
And I should say the caveat that that's probably, I don't know if that would be the same for all lenses, but that's for like my preferred lens with the, the edge lift length of my preferred lenses. And so that may not be the same for everyone, because if you have a smaller landing curve, then you maybe don't need to make as big of change, so it's all a little bit maybe specific to each lens design, but don't be afraid to make big changes, I guess. And it's okay to make 3-step changes or 4-step changes if you feel like you have a long way to go. Because it's way easier to just bracket and almost like overdo it. Okay, now I'm too tight, so I know I'm between here and there. And versus just like inching along and never really making a difference. So if it's a big problem, lots of fogging, lots of edge lift, just make a huge change and then see what happens.
Yeah, I like to go with we have a system in our practice, which is basically EAT, right? So E, edge lift, A, aligned, T, tight, right? And the difference between A and E or T is 200 microns, right? So you can combine everything, and then there's pluses and minuses, right? So if you're AE in a quadrant, you're 100 microns of movement, right? If you're AE plus, you're 150 microns. If you're E, you're 200 microns. If you're E plus, you're 250 microns of change that you need. So we kind of use that as our guideline for this, but generally the smallest change that I'll ever make is a 50 micron change. The biggest one that I'll ever make is a 250, and then kind of go off of that. It's but I'm with you on that, Brooke. Like if it looks aligned and they're telling me, and I still feel it here, and I have done everything, I may give them an extra 50 tuck on it.
Yeah.
But yeah, that's the you feel good about it sort of thing, not a that was necessary sort of.
Yeah,
thing.
it's like, I'm still in warranty, so I'm probably just gonna give this a try, and
yeah,
I'll usually throw on some, something to try and calm down the eyelid too, like Isuvis or Pataday along with that too, just to try and decrease the lid sensitivity.
Oh yeah, 100%. I mean, the big thing. I mean, you don't look for it until somebody's complaining about it, right? Like, how many eyelids have you flipped and been like, oh yeah, they do have GPC, yeah. Why can't I get them comfortable? And it's just
yeah.
Nicole, this one, I'll ask you this one. For that image in the top right, if somebody was to send that to you and they had the Zen lens on, what step change would you tell them to make?
Yeah, and that top right, I mean, I can see it's kind of small on my screen, so you're going to really see my face close. So in this one, you can kind of see that it's coming in, but then I'm looking at at the heel of things, and then I'm seeing you've got that big gap there also. So I'm looking at gaze. They're really kind of looking off to the side. So it's kind of hard to judge. I would probably actually in that upper one, I might not make an edge change, or I might go 2 steps is what I would do. But then I'm also looking when I'm getting out kind of to that limbal and mid-peripheral area and thinking, is it more like a base curve change that needs to be made?
Mm-hmm. Okay.
And then obviously in the bottom one, I mean, yeah, that one needs to be at least 2-3 steps. And in each of our steps is 30 microns. So it's rare that you'll have us recommend 1 step. I mean, if you think about what 30 microns actually is, it's so minimal. So we're always 2 or greater, depending on what things look like.
Yeah, and sometimes I'll use the thickness of the lens to determine okay, so I have if the center of this lens, let's just say the center of the lens is 250, and then yes, maybe the edge is slightly thinner than that or whatever.
Yeah.
I'll try and estimate or even measure on the OCT. Okay, so I have my edge thickness, and how far do I want to bring that down? On this one, I wouldn't mind if I brought the edge down by at least 50% of the thickness of the lens. So if the edge thickness is 200, I need at least 100 microns.
Right. Yeah.
Down, which would be 3 steps in the Zen lens, or however many others that you wanted to do. But I would look at that too. So again, this one, I need 50 to 75% of the thickness of the lens edge to come down.
Come in. Yeah.
Yeah, I'd be completely overhauling the edge of the inferior and temporal quite a bit. And then I'd also remove that front toric, because we don't know where this is going to land once we.
Right.
There's a diopter, 1.75, almost 2 diopters of toricity, front toric. So if you're 50 degrees off, you're really unhappy patient. So I would tell them that it's still going to be a stepwise process. We got to first stabilize this lens and then add the front toric.
Can I ask you guys a question? Do we have time for one more on this, Ariel?
Yes. Mm-hmm.
So 175 OR cylinder is pretty high.
Yeah. I'm not putting that in. There's no way.
Yeah, sometimes patients take a lot of SIL because they actually have HOAs. And the only time I'm adding that much cylinder in a lens is if they have a toric implant.
Yep.
So again, like you said, Nate, I think it was you, and John, bold move on that much cylinder in the first lens. And I usually spherical equivalent and then go from there to see where my rotation lands. But I don't even know that many patients need that much over refractive astigmatism in the lens. I just don't feel like I get that many patients with $2 a SIL on their scleral lens. I don't know.
It was a 25-year-old.
So yeah, hopefully. I don't know.
Sometimes you can get it from lenticular, if it's a 90 degree at the 90 degree, but usually I won't see that high. Unless you got that toric IOL. But I would love for somebody to figure out because we're measuring wavefront, we're measuring HOAs, and a lot of time people confuse coma for astigmatism. But has anyone figured out, like, when we look at coma, like, in what direction it is that, can we tell how they're going to perceive it as astigmatism and at what axis? Because, like, they give you a vertical and a horizontal, but, like, it's the way it traces out, it's not going to be perfectly vertical.
Right, right. I'm not smart enough for that.
Yeah, I know.
Do you guys study anything like that? You guys would be the place to do it.
Yeah, I mean, you know, a lot of this, it's always funny because, like, if you actually watch these patients when you're doing your over refraction, they're never centered in the 4-opter. Every one of them that takes a, 2 diopter cylinder, if you actually, like, flip the light on and look in, what they're doing is they're here, they're barely peeking through the bottom portion of the lens, which, like, at that point you are offsetting exactly the coma, right? You're essentially getting just a single lob of a stigmatic correction, right? And that's what's giving them that great vision, right? The other thing on this too is look at the mismatch between the visual acuity and the amount of cylinder, right? In any patient, if I gave you 2 diopters a cylinder, you should be at minimum 3 lines better, right? Right. I look at this and I go, I guarantee you that patient probably improved 1 line and was like, this is the best vision I've ever seen, And the reason it's the best vision they've ever seen is because it's correcting their coma. So, we get fooled a lot when they, okay, they have this 2 diopters. And then the next thing is, I bet the next over refraction is again something with SIL in it, right? And the vision with the new lens is not that great, right? And then we're chasing this weird over refraction where the orientation of the axis doesn't align, and it's don't get fooled by that. It's
so one quick question, and then our next case. I think we'll have 20 minutes for, but real quick, when using Pataday here to improve comfort, at what point in the day should the patient instill the drop? And is it okay to use when the lens is still on the eye? Hey, do you want to answer that one?
First thing in the morning for me. What about you guys?
Same.
Yep, same. Mm-hmm.
Before the lens.
Yep. Yeah.
Okay.
I have heard of people putting Pataday in the lens, but I don't think I've had patients do that myself.
Interesting. That'd be a move. I don't know. I've never. I mean, I guess it just depends on how allergic the eye is. I mean, I would be much more comfortable doing that with, like, cyclosporin. But I mean, in, like, you think about it, how bad is your allergic conjunctivitis that you're working with, like Ricasa, right? Like, I'd be happy to throw some cyclosporin on it. But.
Yeah, Boston Psych did a study on that, putting cyclosporin in the lens.
Yeah. There's a couple good, like, KC studies looking at, like, progression and cyclosporin. So it's there's some fun stuff there. So I don't know. I think about using cyclosporin on these patients.
There you go. All right, let's go to case 3. All right, patient wears iPrint Pro lenses. He is an ER physician and is required to wear scleral lenses up to 18 hours a day. Has a history of keratoconus and post-LASIK ectasia in both eyes. He presented with complaints of progressive soreness, irritation, photophobia, and injection for the last 6 months. Left eye worse than right, worsening over the past month. The patient self-diagnosed that it feels similar to scleritis symptoms. It is not resolved when taking out the lenses. The symptoms get worse after taking out the lenses and last for a few hours before getting better. He notes improvements in symptoms with Tobradex and has instilled 4 times in the past month, but has felt like wanting to instill every other day. Symptoms are in both eyes, but worse in the left. In examination, we found that the left lens had corneal touch and was recommended to increase the clearance in that lens. Patient wanted to change only 1 lens at a time due to relying on vision for occupation. Here are the lens parameters with the fit and spherocell over refraction. So here are our powers, base curve, material, describing the fit as well centered, 155 central clearance, shallow clearance, inferior nasal over intax, good limbal clearance, seeing some compression, blanching, inferior nasal, scleral alignment elsewhere, black dot at 6. Left eye, well centered, corneal touch over central inferior cone, scleral alignment 360, 3 to 4 plus injection inside and outside the lens, temporal and inferior, 2 black dots at 6. So what changes would be indicated for the right eye, if any? Would it be expected that if the left lens is more comfortable, should the right eye feel better too? Let's jump to the pictures.
Oof.
All right. Yeah, that looks like a couple of angry eyes.
Wow.
So it says that this photography was captured right after removing the scleral lens, which was touching and pressing on the inferior cone.
Did you say that's after removing the lens? I think I see a lens in the eye. Or is it just so
On the
tight
bottom.
it looks like, yeah, the bottom image?
Yeah.
Or,
so-
no, of course, there's 2 dots there. What am I saying?
Yeah, it is saying that that top left was right after removing the scleral.
Okay, gotcha.
Yeah. Okay.
Sometimes I see that red, it can be a solution issue too, that they're not rinsing off because there's not really blanching there. It looks like the eye's just red.
Just really irritated. Yeah.
Yeah.
Let's go to the next picture. There we go. So it's showing the left eye OCT images where it's talking about that touch.
Mhm.
Bone, central clearance, bottom left, and then our edges.
Didn't the case history said that the left eye had blanching 360? I think that might have been misinterpreted.
Let me go back to it real quick. It says compression, blanching, inferior nasal, and goods alignment elsewhere. Oh wait, no, sorry, left eye. It says scleral alignment 360, 3 to 4 plus injection inside and outside the lens.
Injection.
Yeah. So when I feel like there's injection like inside and outside, so they've got like limbal. So the compression is like right outside the limbus, so it's pulling in that limbal tissue. So when I see kind of that perilimbal redness inside the lens, yeah, to me the approach to the limbus is too steep. So I'd want to change that contour both in the middle of the lens and the limbal clearance to make it more like tangential to the ocular surface. So I'd be looking at like how steep is my limbal approach to the limbus area.
Great. I think we have one more set of pictures next.
The
Don't
other
go the other way. Oh wait,
Oh, here we go. Okay.
there we go.
There we go. Now we're clear.
And that edge is probably a little tight.
Yeah, both nasal and temporal.
Mm-hmm.
Up and down looks okay.
Yeah, but like John said, if you just put it to that narrow beam, you can look at the up and down a lot better.
Mm-hmm.
Oh, I thought they were going to do that beam. Oh, maybe we have it. $173. I think this lens is out of warranty. We're up to like the 189s now, I think.
Yeah, and the right lens did have central clearance, though, correct? It was the left that had that touch, or was there touch?
No, they both touched.
Right? Did they both touch? Okay.
Yeah.
So when I'm looking at that right lens, go back to that rear. Well, let the left play at the same time. We'll play them both. But
is there a way to put it on replay? I think you can.
Not sure. I'm not driving this.
Oh, okay.
Yeah, I mean, the inner side of his lids just look really upset. I mean, I wonder how this guy's eye looks like when you just tell him stop wearing the lens.
Yeah, he's probably got rosacea and,
I mean, everything just looks kind of hot.
yeah. Oh, that left eye. Holy.
Yeah.
Oh, ouch.
I don't know. When I look at, so if I look at eyes that are just generally red, my immediate thought is what's going on with the cornea, right? If you're generally red, you got a couple things potentially going on, right? We generally have, and let's say, let's set up a very specific scenario, right? Let's say this guy came in and had, trace diffuse redness or injection, right? And then they came back looking like this, right? My first thought's solution reaction. My second thought is going to be, okay, what are we doing to the cornea underneath it? Because those lenses don't look horribly, fit. I'm more so thinking, okay, what else is going on here that could make this eye red, right? When you look at this, usually you get the stripe, right? If you have a lot of redness, you're going, okay, either the lens is digging in here or the lens is so, compressed in a flat direction that you're getting some compression in that area, and that's causing the issue, right? I think the main issue when you're looking at this is he definitely has touch on both corneas, right? So that's certainly going to make the eye red and irritated and upset. I'd keep it simple with this one to start. Literally, I would just lift the clearance.
Can you go back to the OCT?
Yeah.
Because my only thought there, John, is like sometimes you have lenses that kind of graze the cone and they're maybe Intact's, like Intact's eyes. Those eyes are so sensitive. But like sometimes when it's like grazing the cone, they don't even know it. They just like.
Yeah.
But Intact's eyes are a different beast. And so if this is the eye with the Intact's, then I would definitely get off that cornea.
Yeah. I will tell you that was the thing. Like when we were going through that cross section, optic section of the eye with the Intact in there, you're real close to that Intact ring. And I will tell you those things. I mean, I'm sure everybody here has seen an Intact with a melt over the top of it, or, a worst case scenario, extruding, I mean, this is not funny at all, but like, at the same time, so I saw a patient who had an Intact ring on, Monday and had some, focal confluent SPK over the segment. No obvious thinning at that point, but definitely a little, for sure, epithelial modeling and that sort of thing. She came in the next Monday as an emergency with a full, stromal melt right over the top of it. So, these things can go south very fast. So in general, I say, get that thing off the cornea.
I wonder how it was to take the lenses out, because that's something that I always do with my patients. I'm the one who takes them out because I want to know how much suction it took to take it out. And I recently had an impression patient who was wearing an 18 millimeter lens. The eye was white and quiet. He was complaining that his eyes were, he's also a physician, ER physician, and wear them for 18 hours. And he'd say that it feels like his eyes just felt really sore when he was wearing them, especially toward the end of the day, and that he has a hard time taking them out. And I was like, really? Okay. So he'd had them in for like 6 hours, and I went to take them out. And usually these lenses, they come out pretty easy. I literally had to like push my thumb into his eye and pull at the same time. And I was pretty shocked that it was so white and quiet and no blanching. And then when I took that lens out, it was really tough to take out. But then his eyes got like super red, so I guess it was a lot of rebound hyperemia as well, and there was a bit of a ring there with the fluorescein.
I think the thing that I always see with that, and this is this is the classic issue that everybody runs into. Well, the eye is white and quiet, the fit looks great, the patient's uncomfortable, right? So what's going on? Almost always you try to take that lens off, it has a ton of suction, and when you take it off, the limbus is stained 360 degrees around. So your main thing here, make sure that you're up and away from your limbus. When I looked at those OCTs, if we go back to those real quick, right, I might say that on that what is that inferior right image, right, we're away from the limbus for sure. You're on that superior right, I don't know, we don't have enough to really give me an idea of what's going on there. It looks like you're probably beyond it, but I mean, you can't see enough of where is the cornea on that to really know, are you just like way beyond it and throwing a whole bunch of suction force there? Or are you, I don't think that's epithelium there at all. So that just looks kind of like conj. But, in some of these, you get a big wide landing area that's like really, really aligned to the eye. I mean, it's the blessing and the curse of using an eye print lens, right?
There's no relief to the conj.
Exactly. It's just
the perfect fit, sometimes too perfect. Yeah.
I remember that in my residency year. My first fits, everybody loved them, even though they were probably terrible, but at the end of the year, then I started getting these like tight lens syndrome. As I got better at fitting them, I started getting tight lens syndrome like symptoms.
So it's funny. One question came in, and this will probably be the last question that we have time for. He asked, what about fitting base curve a half diopter flatter and increasing the diameter slightly in case it decenters?
I don't know that I want to increase the diameter on this. I think it's already plenty big. In fact, sometimes like all that redness, I'd consider even a smaller landing zone. The chamber size is different. So like, it's, do you want to increase the chamber size or increase the overall diameter? Because it's different, especially in an eye print, because you can make the landing curve longer, you can make the chamber bigger. They're all independent from one another. And so when you make it bigger, you got to know what you're making bigger. Is it the chamber? Is it the landing? Is it both? And a lot of the times, like making the chamber bigger just allows for the lens to further decenter. So I don't necessarily like that. I would, maybe if you could get this guy on a steroid twice a day and try and calm his conj down a little bit, you might need to remold. I don't know if you can get him to take a break. Perhaps they molded when his eye was a little bit inflamed, and now it's, having a hard time finding like a happy place to be, which is sometimes what happens with these eye print eyes. Nothing else works, and so you mold them, and then they're, so it's tough. These are tough eyes.
Yeah. I mean, it's a challenge with it for sure. And, I mean, as customizable as an eye print is, it's not super flexible in the way that you can modify it because, you can't tip a haptic down or up, right? You can lift, but that's not the same as, I want to bring the toe up or the toe down, right? Yeah. So it's always a little challenging on this, in this, I mean, I would try to probably lower that limbal approach there. Generally, when I see eyes like this, I kick out my limbal point further, and that sounds crazy, but I go, exactly what you just did there, Brooke. Like I kick it out and then lower it, right? So you're just getting a much shallower approach there, and that generally helps to resolve things. So it's kind of, in this case, lift your central clearance, bring down your mid periphery, and then go ahead, kick out your limbus. And then you should have at least some of the suction relief and that sort of thing. But yeah, that would be it. But I like the idea of the steroid see how he does with that. Just kind of calm things down. Get that lens off the eye, stain the eye. It's going to tell you the story, right? It's going to say, oh, we got an arcuate stain here. We're digging in there, those sorts of things. So, yeah.
Have any of you tried landing zone fenestrations on fits that are like this? I mean, other than it bearing on the cornea there.
Yeah, I'll tell you for my experience with it, I have very mixed results on it. I will tell you that in a lot of these, you'll have a fenestration hole that you'll put through it, and then they end up staining around the area where the fenestration hole is, and then they'll go, oh, I'm like more uncomfortable in red. I mean, I don't know. In some cases, it really solves the issue. In other cases, it just makes things worse. So,
that's
again,
experience.
I'm not super confident in it.
I would agree with you, John. It's not my first choice anymore.
Yeah.
All right. Well, it is Nicole's time to shine. So I'm so blurry. But thank you guys so much for all of your input on these cases. It's really awesome to have all of your input, and I wish I could carry you guys with me to clinic. Like, what do you guys think of this?
We never get anything done.
Yeah.